assess the level of your knowledge. Then here at Auricle, we have 3 different subscription plans available. That is the basic, which comes at 15,000 and it is for 3 months. Then the standard plan followed by the mentorship plan, which is for 12 months and comes at 50,000. And in the mentorship plan, we provide you with notes as well as personalized guidance and live doubt clarification sessions as well. Then you can avail a 20% discount by using my promo code as displayed on the screen. Then a very unique feature of Auricle is that we also provide you with personalized counseling sessions. So from our end, not necessarily pertaining to academics, then also you can feel free to contact us. So if you want to book a slot with us for personalized counseling sessions, please feel free to do that. So that was a little introduction. Now let's begin with our class on mineral metabolism. The previous class we'll be covering iron, very important, everything associated with it, and followed by calcium. So talking about, to begin with, the sources, RDA and absorption of iron. Then we'll talk about the transport and biological functions for disorders, iron deficiency, anemia being the most important. Leafy vegetables, jaggery, pulses, they are important sources for iron. Now your milk is a poor source of iron and copper. Now moving on to the absorption of iron, a very important topic. So your food has Fe3 plus iron, okay? So the dietary iron is in the form of Fe3 plus, but iron in the form of Fe2 plus. So when I discuss about the mechanism, we will see how this is converted into Fe2 plus. Now the factors that reduce iron absorption, they are your phytates, oxalates, phosphatase, and tannates. So these are the factors which are going to reduce iron absorption. Now the factors that increase iron absorption include vitamin C, cysteine, and iron is in the form of Fe3 plus. Now Fe3 plus is the oxidized state and Fe2 plus is the state in which iron is absorbed, and Fe2 plus is the reduced state. So here the factors that increase absorption, they are those factors which are going to cause this reduction. Okay, so those factors which are going to act as reducing HCl and vitamin C and all, they are the reducing agents. So they're going to reduce iron, they're going to increase iron absorption by causing the reduction of iron, okay? That is converting Fe3 into Fe2 plus state. Now talking about the recommended dietary allowance, that is RDA. So for men and post-menopausal women, it is 10 to 20 mg per day. For pre-menopausal women, it is 20 mg per day. Requirement is increased because of 13 to 30 mg per day. And during pregnancy and lactation, again, the requirement is increased and it is 20 to 40 mg per day. Now, talking about the mechanism of iron absorption, very important. So, what is happening is, firstly, one source of iron, an important source, that is through diet. Okay, so diet forms source. One is through diet, okay, and the other is through recycling of the recycling of iron from RBC destruction. Okay, so from the recycling, iron recycling from RBC destruction. Okay, so I'll take both of them. Now from the diet, either you can have iron in the form which is in heme form, or either you can have it in non-heme form. So first I'm going to talk about the absorption of iron, which is in the non-heme form. So your dietary iron that you are consuming, which is in the non-heme form, it is in Fe, not in the form of heme, it is in the Fe3 plus state. Now let's talk about how this iron is absorbed. So it's you have enterocytes that are your intestinal cells. Okay, they have a brush border. Okay, so this is the intestinal luminal side. Intestinal lumen on this side, and this side is your blood. So now this dietary iron that you are consuming, it has to be absorbed from the lumen through the enterocytes, and that is the intestinal cells into the blood. Now let's have a look at the mechanism which is going to take place. So I just told you that the dietary iron, which is not in the heme form, it is the Fe, the absorption state, as we just mentioned in the first sentence, that is Fe3 into Fe2 plus. So your dietary iron, which is in the Fe3 plus form, this has to be reduced to Fe2 plus. Okay, now this is taking place by duodenal cytochrome B. Okay, these duodenal cytochrome B, they are present on the luminal side of the enterocyte. Okay, they are known as duodenal cytochrome B. Okay, now other reducing agents can also cause this conversion, that is conversion of Fe plus 3 into Fe2 plus state. That is, like we just mentioned, vitamin C, your gastric acid, HCl. Okay, so they can also cause this. Now what happens? This iron is in the Fe2 plus state. This transporter here that I have shown you. Now this iron is going to enter the enterocyte through this transporter. Okay, Fe2 plus is inside the enterocyte, and the name of this transporter is, it is known as divalent metal transporter. This is known as divalent metal transporter, DMT1. Okay, so since I'm saying it is a divalent metal transporter, so not just iron, but it is also going to transport other divalent metals as well, like your, you can say manganese, uh, then your copper, zinc, lead. Okay, so it is going to be transporting these other divalent atoms as well, elements as well. Okay, now this Fe2 plus is inside the enterocyte. The excess of this is going to be stored in the form of ferritin. So your ferritin is the storage form of iron. Okay, and the other iron, that is the demand, which how much is required by the body according to the body's demand. If there's some excess, is going to be stored. Otherwise, the rest of it is going to be transport protein. Okay, so you have this ferroprotein here. This ferroprotein, it is going to transport this Fe2 plus out into the blood. So you have Fe2 plus here in the blood. Now what is happening? There is another protein known as here. Now this Fe2 plus, it is going to be converted into by this protein into Fe3 plus. Because the carrier protein for iron, it has affinity to binding sites for Fe3 plus. And transport protein is known as transferrin. Okay, so this transferrin, it can Fe2 plus that was coming out of ferroprotein. It is again converted back into Fe3 plus via a protein which is known as hapstin. Okay, now this Fe3 plus, it is going to bind to transferrin. Now this transferrin, it is the transport form of iron. So iron is going to be transported to the target cells with the help of transferrin. It has binding sites and affinity only for Fe3 plus. So it can bind iron in the form of Fe3 plus only. Now, another important thing that you need to know is that free iron is very toxic, okay? Since it is capable of producing what is known as your reactive oxygen species, the reaction is known as Fenton reaction, okay? In short, just know that free iron, it has the capability of producing the free radicals are. Therefore, your iron is always stored or transported with the help of proteins. Okay. So now this transferrin, it is going to transfer the iron that is absorbed from the diet to the various target cells, organs where it is required. So this was the mechanism of absorption of iron from the diet through the enterocytes, that is intestinal cell, into the blood, and then it is transported to the respective target organs. Now, is that first your heme, it is going to be broken down, and then it is going to enter the cell. The enzyme known as heme oxygenase is going to work, and then Fe2 plus is going to be released, and then again ferroprotein is going to transfer that Fe2 plus out of the cell, and then instead of your hepastine acting, your ceruloplasmin. We discussed that period is going to work. Okay. And similarly, the other iron from the RBC 20 days. Okay. So after 120 days, the old or damaged RBCs, they are destroyed. So they are phagocytosed by macrophages. So inside the macrophages, your hemoglobin, first it is going to split to give globin and heme are going to separate. Then this heme is going to be acted upon by an enzyme, and your Fe2 plus, that is iron is released. This iron is going to plasmin to convert Fe2 plus into Fe3 plus. Now this Fe3 plus, it is going to bind to transferrin. That is, transferrin is the transporter of iron, and then this transferrin is going to transfer or transport iron to the respective target cells. Okay, so that was about the mechanism of iron absorption. So let's see what the notes have to say. So iron absorption, the various steps. First one, the stomach entry. So the iron enters the stomach and it is oxidized. Okay. Followed by gastric conditions, your gastric acid and ascorbate, that is your HCl and your vitamin C. They prevent iron precipitation, that is, they help in iron absorption. Then mucosal cells in duodenum absorb iron. You just seen how. Then iron couples to transferrin in the circulation. Transferrin is the transport protein. So after being absorbed via the enterocytes, it is transported out via ferroprotein, and then it is carried to the respective target organs via this transport protein known as transferrin. Now, factors blocking absorption, we have already discussed. They are phytates, tannins, antacids block iron absorption. Then gastric influence, the gastric acid enhances ferric iron solubility. Impaired gastric acid reduces iron absorption. Okay. Now talking about heme absorption differs from inorganic iron. Meat is rich in heme and it is an excellent iron source. So from animal sources, you're getting iron in the form of heme, and from plant sources, you're getting dietary iron in the form of Fe3 plus. Then blockade of heme catabolism may cause iron deficiency. Dietary factors, ascorbate and citrate, they aid iron uptake, and phytates and tannins, they inhibit iron absorption. Then lead impact. Lead uptake competes with iron absorption. So lead interferes with iron dependent metabolic steps. Now it is very clear why, because here I told you that the enterocytes they have DMT, that is divalent metal transporter. So not just it is transporting Fe2 plus, but it is also transporting other divalent metals. Okay, so your lead, in case of lead poisoning, this lead is going to compete with iron. Therefore, it is going to lead to iron deficiency. So here we have this diagrammatic representation of the mechanism that I explained to you. Now talking about important terminologies or elements required in iron absorption, we've already discussed all of them. So let's just take them again one by one. DMT, that is divalent metal transporter. So it transports iron, copper, cadmium, zinc, manganese, all of the divalent metals. Now it is coupled with hydrogen expression regulated by body iron stores. Now talking about hepastine, it is homologous with ceruloplasmin, a transmembrane protein, and it has perioxidase activity. Okay, so your hepastine, it is present in enterocytes. And your hepastine, it is present in enterocytes, and analogous to it is your ceruloplasmin. So your other cells apart from enterocytes, they are using ceruloplasmin, which is a copper containing enzyme. We already discussed them when we were talking about copper. Both of them have similar activity, that is they convert Fe2 plus into Fe3 plus. Okay, the difference is that your hepastine, it is present in enterocytes, whereas the other cells, they are using ceruloplasmin. And another thing is that your hepastine, it is a transmembrane protein with ferrooxidase activity, whereas your ceruloplasmin, it is present in plasma. Okay, so there are 2 points of differences. That is, ceruloplasmin is present in plasma. Hepastine, it is present it is a transmembrane protein, so it is present in the membrane. But similarity is that both of them have ferrooxidase activity. And another point of difference is that your hepastine is utilized by enterocytes, whereas all the other cells, they use ceruloplasmin. Now talking about hepcidin. Okay, now what is hepcidin? So it is an acute phase protein synthesized by liver. It inhibits ferroprotein and iron absorption. It is responsible for anemia and chronic inflammation. So your hepcidin is basically a peptide which is synthesized in the liver, and it is playing a central role in iron homeostasis. Okay, so your hepcidin plays a central role in iron homeostasis. How is it playing a role? Because it is able to bind to your ferroprotein. What was ferroprotein? We just discussed here. See this picture that I drew? This ferroprotein was transporting your Fe2 out of the enterocyte, okay? So it was involved in absorption from the intestine or from the it is also present in macrophages, where your hemoglobin, the iron from the hemoglobin that was released was also being passing out through ferroprotein. Okay. Yeah. So this hepcidin, it is going to bind to ferroprotein and then cause internalization and degradation of your ferroprotein. As a result of which, what will happen? Your iron will not be absorbed. So leading to what is known as anemia. Now, mucosal block theory. The iron homeostasis regulated at the level of absorption, not excretion, and iron is a one-way element. So basically, it is trying to say what is going to happen. I'll just draw a picture here. See, this was your enterocyte. You had your dietary iron, which was in the form of Fe3 plus. Then via duodenal cytochrome B, it was being converted into Fe2 plus. Then this Fe2 plus was entering the enterocyte via what is known as your divalent metal transporter. Now this Fe2 plus was being absorbed into the blood and moving out from the enterocyte into the blood via what is known as your ferroprotein here, this one. So this is your ferroprotein. Now Fe2 plus was coming out, and this Fe2 plus was then being converted into Fe3 plus and then binding to transferrin. Now this ferroprotein, it is blocked by what is known as hepcidin. So here in red triangular forms, this is hepcidin. Okay. This here that I have shown, this is hepcidin. So hepcidin, it is going to bind to ferroprotein and cause the degradation of this ferroprotein. Now, as a result of which, this will not work. Okay. So your Fe2 plus is not being coming out of the enterocyte. That is, it is not being absorbed. Okay. So there is decreased absorption of iron, and this is known as mucosal block. So decreased iron absorption in the intestine is your mucosal block. Decreased iron absorption in intestine. Okay. And also this ferroprotein is also present in macrophages and having the same function. Okay. Okay. I'll draw this here also in macrophages also so that you understand that how your iron is being recycled. Actually, I've limited space now. Anyway, so what is basically happening is your hemoglobin, which is present in the RBCs. Okay, so your RBCs have a lifespan of 120 days. After 120 days, your old or damaged RBCs, they need to be destroyed. Okay, so they are phagocytosed. This is what I've shown here is a macrophage. Okay, so they are phagocytosed, that is engulfed by macrophages. Now, once inside, what is happening here? This hemoglobin, it is going to split and your globin is removed. And what you get? Hemoglobin is composed of heme and globin. So you have heme here. Now this heme, it is acted upon by an enzyme which is known as heme oxygenase. Okay. Now the iron from the heme is released, and the iron that is present in the heme is in Fe2 plus state. Okay. So this iron is released and you have biliverdin form here. Now biliverdin to bilirubin and all that, that is another story. So we're not discussing that beyond the scope of today's class. Now, anyway, this Fe2 plus that is released via the action of your heme oxygenase. Now, this Fe2 plus is going to move out of the macrophage, and again the transporter here is your ferroprotein. Okay. So your Fe2 plus is going to move out. Now, since this is a macrophage and not an enterocyte, so your ceruloplasmin is going to work here, and this Fe2 plus will be changed into Fe3 plus. Now, again, transferrin will come, bind to this Fe3 plus, and then this iron will be transported to the respective target organs. So here, what is going to happen? Again, this ferroprotein is going to be blocked by hepcidin. So, hepcidin can bind to ferroprotein present in macrophages and also present in enterocytes, causing what? Causing decreased absorption of iron and also decreased recycling. Okay. Ultimately leading to decreased iron, okay, in both the cases. Okay. Because there is decreased iron recycling by the macrophages and also there is decreased absorption in the intestine. So that is about all that you need to know about hepcidin. Now moving on to transferrin. Transferrin we've already discussed that it is the transport form of iron. It is measured as TIBC, that is total iron binding capacity. That is measured as TIBC. Now moving on to the storage forms of iron. Ferritin, readily mobilized form of stored iron. So the excess iron, that more than what the body needs, that is stored in the form of ferritin. Your homosiderin, it aggregates for several ferritin, higher iron content, and release iron more slowly. Now talking about the functions of iron, physiological functions of iron are carried out through iron containing proteins, which can be categorized into heme proteins and non-heme proteins. So your functions of iron, they are manifested through the enzymes or the proteins that are containing iron. So again, they are divided into heme and non-heme. So a lot of proteins, they contain iron in the form of heme. So they are grouped as heme proteins, and the others which contain iron but not in the form of heme. So in heme protein, iron binds with protoporphyrin 9 to form heme. So iron is basically present in the form of a porphyrin ring. So if that structure is present, then you say that these proteins, they are known as heme proteins because they contain iron bound to protoporphyrin 9, forming porphyrin rings, okay, which then associate with different globin molecules to create heme proteins. These proteins play various roles in the body. So the most important heme protein is your hemoglobin, which makes about 70% of the total body iron, very important, involved in oxygen transport and is a crucial respiratory and buffering protein in the blood. Then moving on to myoglobin, it comprises approximately 5% of the total body iron. Myoglobin is an oxygen storage protein found in the muscles. Then your cytochromes, they are also heme proteins, and cytochrome B, C, C1, A3. So we came across all of these in electron transport chain. Again, very important, they're involved in oxidative phosphorylation. Now your cytochrome P450, it is present in the liver, and this enzyme is involved in detoxification of foreign substances, that is xenobiotics. Now your catalases, they function to break down hydrogen peroxide. Peroxidases, the examples include myeloperoxidase found in neutrophils, which aid in phagocytosis. Now, other heme-containing enzymes, they are your tryptophan pyrrolase. Your tryptophan pyrrolase is the enzyme which is involved in tryptophan catabolism. Your xanthine oxidase, it is involved in purine nucleotide degradation, and it produces what? Uric acid. So these were all the examples of heme proteins. Now talking about non-heme proteins. Non-heme proteins do not contain heme but contain iron. So iron is present, but it is not present in the form of heme, which is tightly bound to these proteins. They serve various functions in the body. Your ferritin, it acts as a storage form of iron and primarily found in spleen and liver. It contains up to 24% of the total body iron. Okay, so the iron, free iron is very toxic. So it is handled always along with proteins. Whether you transferring it or you storing it, it is always done in combination with proteins. Your hemosiderin is another storage form of iron, mainly present in the liver, particularly in conditions of excess iron storage. Now, the transferrin, it serves as the transport form of iron. So, your transferrin is the protein which is involved in transportation of iron. So, it has binding sites, two high affinity binding sites for Fe3 plus. Then, talking about iron sulfur proteins or enzymes, if you remember when we're talking about complexes in electron transport chain like the NADH dehydrogenase, that is complex 1, the succinate dehydrogenase. So all of them, they were containing iron sulfur clusters. Then your choline dehydrogenase, glycerol phosphate dehydrogenase, ribonucleotide reductase, and many more enzymes, they all have iron sulfur complexes. Then talking about aconitase. Now aconitase was an enzyme involved in Krebs cycle. There I had told you that it is a moonlighting enzyme. And what are moonlighting enzymes? Enzymes which have another role apart from their enzymatic role. So your aconitase, it is involved in iron homeostasis. Now talking about iron deficiency anemia, it is very important. Okay, so it is the most common nutritional problem in India. Hemoglobin level is decreased, your ferritin level is decreased, but your TIBC is increased, and it is manifested as microcytic hypochromic anemia. So if we talk about iron deficiency anemia, your iron deficiency anemia, it progresses through 3 stages, okay? Iron deficiency anemia, it progresses through 3 stages. What are those 3 stages? The first being negative iron balance. The second being iron deficient erythropoiesis. And then finally, iron deficiency anemia. So what do we mean by negative iron balance? So this is the initial stage and there is insufficient intestinal iron absorption. Okay. So this is the initial stage and there is decreased intestinal iron absorption. So iron stores are mobilized to meet the body's demand. Okay. So your iron stores are mobilized to meet body's demand. And as I just told you that your ferritin is the storage form of iron. So the excess iron in the body is being stored as ferritin. So what will be decreased? You will at this stage see low ferritin levels. So this negative iron balance, this initial stage of iron deficiency, it is that stage where all your other tests will come normal, but you will see low ferritin levels. Okay, so in this stage, there is decreased intestinal absorption because of which your iron stores will be utilized and therefore you will get low ferritin levels. Now, if this iron deficiency is not met, like either you're not taking iron through diet or whatever, if this deficiency continues, then you enter the second stage. Okay, now what is happening in the second stage? When your ferritin level falls below a certain value, that is 15 microgram per deciliter. Okay, if it falls below this, becomes less than this, if your ferritin level becomes less than this, then what happens? Your transferrin in the blood is increased. Why is transferrin increased? Because transferrin is involved in transport again. So your transferrin level will be increased, but transferrin saturation will be decreased. Okay. So therefore, because of increased transferrin, what happens? Your TIBC increases. Okay. So your TIBC is going to increase, your transferrin level in the blood is going to increase, but your ferritin level is going to fall down. Now, if this iron deficiency is not corrected, what will happen? Your hemoglobin synthesis will be impaired. So your hemoglobin is going to decrease and it is going to manifest as iron deficiency anemia. It is going to lead to iron deficiency anemia. So these are the three stages of iron deficiency. First, in the initial stage, there is decreased intestinal absorption because of which your ferritin stores are mobilized. Then if it is further not corrected, what will happen? If your ferritin levels falls below a certain value, that is 15 microgram per deciliter, what will happen? Your transferrin level will increase in the blood, your TIBC will increase, and then your erythropoiesis will be impaired. It is going to be affected. Then you will have decreased hemoglobin levels, and then finally it will lead to what is known as iron deficiency anemia. Okay. Now talking about iron overload. So in this, there's excess iron, there's excess ferritin. Okay. So excess hemosiderin leads to hemochromatosis. What is hemochromatosis? That is iron overload. Now, clinical features include diabetes, there's a skin pigmentation. So together they're known as bronze diabetes, okay, because it is going to affect your pancreas and there will be pigmentation on the skin. So it is known as bronze diabetes. So this is taking place in case of excess iron in the body. Now, you might get a question on iron deficiency anemia, a long question that you have to write in detail about iron deficiency anemia. So we discussed the major portion, how it is going to take place, the various stages. So let's have a look at the causes of iron deficiency anemia. So there's decreased iron intake. The most obvious cause that you're having inadequate dietary iron. Okay, so that is going to be one cause. Then the other cause can be there's lack of iron absorption. So either there's inadequate intake or there can be decreased absorption in conditions like steatoria, that is, you have excess fat in the stool. Then tropical sprue, that is again a malabsorption syndrome. Gastrostomy, that is a part or all of your stomach is removed. So that is going to lead to decreased HCl. So again, your iron absorption is going to be affected. Then gastric carcinoma or a condition known as achlorhydria, where there is lack of HCl required for iron absorption. Then lead poisoning. We've also discussed this, that in case of lead poisoning, this lead is going to compete with DMT and lead to decreased iron absorption. So these are the various causes of decreased iron in the body. Now, causes of increased iron loss. Excuse me. Now, the another cause can be that there is increased loss of iron in the body in case of hookworm infection. Then in case of repeated pregnancies, then bleeding in the urinary or genital tract, peptic ulcers, hemorrhoids, so all the conditions that lead to blood loss, menstruation, excessive bleeding, nephrosis. So all those pathological conditions where there is increased blood loss. So increased blood loss will actually cause increased iron loss. Now talking about the manifestations of iron deficiency anemia. So it is manifested as microcytic hypochromic anemia. Microcytic, that it is small, and hypochromic, that is less pigmented. Okay, so due to decreased synthesis of hemoglobin, as you have less iron, so your erythropoiesis, your hemoglobin is going to be low, your erythropoiesis is going to be affected, impaired, and as a result of which your hemoglobin is going to be decreased. So your red blood cells, they are small, microcytic, and underpigmented, that is hypochromic. Now, microcytic hypochromic RBCs are quickly destroyed in the reticuloendothelial system, leading to anemia. Now, another manifestation is atrophic glossitis, that is inflammation and thinning of the tongue's mucous membrane. Here you can see this in the picture. Then atrophic glossitis, that is abnormal thin membrane-like growth in the esophagus. Okay, the page is taking some time to load. Yeah. Then dysphagia, that is difficulty in swallowing. So all of this, these triad symptoms, they together are known as Plummer-Wilson syndrome. Okay, so the triad is dysphagia, iron deficiency anemia, and esophageal webs. Now, other manifestations include spoon-shaped appearance of fingernails, then apathy, that is loss of interest, pallor of the skin and tissues, fatigue, weakness, giddiness, blurred vision, anorexia, that is loss of appetite, impaired immune functions, bone deformities, and headaches. Now talking about why is iron considered as a one-way substance. So first reason being efficient utilization. It operates in a closed system, efficiently utilized and reutilized by the body. Minimal iron losses through bile, sweat, hair loss, etc. Not excreted in urine, distinguishing it from other substances. So the iron losses, they are minimal. Non-excretion, unlike vitamins or other substances, iron is not inactivated or excreted during metabolic function. Then controlled entry. Its entry into the body is controlled at the absorption level, meeting body's demand. Then increased demand, periodical blood loss in menstruating women, and increased demands in pregnancy, lactation, and growing children determine iron requirements. So, as a result of these above mentioned factors, iron's unique characteristics make it appropriately regarded as a one-way substance. So, that was all you need to know about iron. Moving on to calcium. So talking about the sources, RDA and absorption first. So the RDA in adult, it is 0.8 grams per day. In children, it is 0.8 to 12 grams per day. And in pregnancy and lactation, it is 1.5 grams per day. Dietary sources, the rich sources are milk and its milk products. Good sources include egg, fish, mutton, dates, vegetables like broccoli, but not spinach. Okay, so your broccoli is a good source of calcium, but not spinach. Cereals except rice, millets like ragi, bajra. Now talking about the absorption of calcium. So now three factors maintain the calcium level in the body. What are those three factors? One is vitamin D, that is calcitriol. Then the other one is PTH, that is parathyroid hormone, and then calcitonin. So these are the three factors that are involved in maintenance of calcium level in the body. Now, the sites where calcium regulation is taking place, so these are the factors involved. And if I talk about the sites where calcium regulation is taking place, so kidney, intestine, and bone. So these are the three sites where the regulation is taking place. Now, your vitamin D and your parathyroid hormone, they increase the intestinal absorption uh, by increasing a particular calcium receptor and a calcium binding protein known as calbandin in the intestine. Okay, so your vitamin D and parathyroid hormone, they increase. I'll write it. Okay, your vitamin D, it increases serum calcium, and your parathyroid hormone also increases serum calcium. Let's see how. So, firstly, vitamin D, it is going to increase bone resorption. Okay. Secondly, it is going to increase calcium absorption in intestine. And it is also going to increase calcium reabsorption in kidneys. And your parathyroid hormone, it is also having the same effect. That is, it is going to increase calcium reabsorption. It increases resorption in the bones. It increases calcium reabsorption in the kidney and increases calcium absorption in the intestine. Now, why is it causing bone resorption? Because your osteoblasts, they have a rank ligand. What is osteoblast? That is the bone forming cells. Okay, so your osteoblast, let's suppose if this is an osteoblast, I'm talking about the mechanism of these 3 points that I've mentioned, that it increases bone resorption. So I'm talking how your vitamin D is increasing bone resorption. Okay, so your osteoblast, that is the bone forming cells, they have a ligand known as rank ligand. Okay, now the receptor for this rank ligand is present in pro-osteoblast. So this is the receptor and this is rank ligand. It is present in pro-osteoclast. This is pro-osteoclast. So your vitamin D is going to increase the activity of this rank ligand. So this rank ligand is going to bind to this its receptor present on pro-osteoclast, and what is going to be formed is a mature osteoclast. And what is a osteoclast? It is a involved in bone resorption. So mature osteoclast is going to be formed, which is involved in bone resorption. So that is how your vitamin D is causing increased bone resorption. Now talking about increased calcium absorption in the intestine, how is this taking place? So vitamin D, it increases the level of a particular transport channel known as TRPV6. Okay, a particular transport channel, that is TRPV6, and a calcium binding protein known as calbindin. So this is going to increase calcium absorption in the intestine. And in the kidney, it is also going to increase calcium reabsorption. Okay, so in the kidneys, calcium, there is more reabsorption of calcium in the kidney. So all of these three effects together, what are they going to do? They are going to increase serum calcium. Okay. Now talking about the storage of calcium, it is stored in bones, teeth, muscles. Teeth calcium is not used to maintain blood calcium levels. Talking about its excretion, approximately 500 microgram of calcium is excreted in urine daily. Then the biological functions of calcium, bone and teeth formation, it is involved in bone and teeth development. It is also involved in blood coagulation, very important. Then muscle contraction, transmission of nerve impulses, neuromuscular excitability, hormone reactions, release of hormones, activation of enzymes. So all of this, that release of hormones, activation of enzymes, no, because there are various calcium binding proteins like calbindin we just discussed. Then there's another known as calmodulin, that is another calcium binding protein. So when there is intracellular release of calcium, so there is intracellular increase of calcium levels, the calcium levels in the cell increase, then this is going to act as a signal for various enzymes. Okay, so it is going to activate various enzymes. Or this we're going to discuss in signal transduction. So there also calcium is a very important role. Then maintaining the membrane integrity and cell permeability, cell to cell contact. Then talking about the normal biological reference range of calcium, it is 9 to 11 micrograms per day. Disorders associated with hypocalcemia. So one is vitamin D deficiency. Why we've already discussed, because if there's vitamin D deficiency, what will happen? There will be decreased iron or decreased calcium. Then hypoparathyroidism again, because it is also your parathyroid hormone is also involved in calcium regulation. So if there is decreased parathyroid hormone, then also your calcium levels will be affected. Surgical removal of parathyroid hormone. Obviously, when the parathyroid gland, when the gland itself is removed, there will be no hormone. So leading to hypoparathyroidism. Again, your calcium levels, that is, you will have low calcium levels. Dietary calcium deficiency, chronic renal diseases. Why chronic renal diseases? Because there will be decreased calcium reabsorption from the kidney in case of renal diseases. Now, the manifestations include increased neuromuscular excitability, tremors, tetany, muscle cramps, Chivostic sign. Now, what is that? It is a clinical sign that someone is having low calcium levels. So here, what is happening? There's abnormal twitching of the facial muscle. This abnormal twitching of facial muscles. Okay. So what is going to happen here is when the facial nerve is tapped in front of the ear, like somewhere here. Okay. If you tap, so your the facial muscles of that side, they're going to contract. Okay. So if this is happening, it is a sign of low levels of calcium. Okay. So this is known as Chivostic sign. Then other is Trousseau sign here. What is there? Then it is observed as carpopedal spasm. So there is frequent involuntary muscle contraction in the hand and feet. Okay, it is going to be seen something like this. Then bone deformities, increased urinary calcium excretion, renal calculi, bone deformities, ectopic calcifications, anorexia, depression, muscle weakness. All of these are manifestations of hypocalcemia. And then talking about hypercalcemia, that is increased calcium levels. So in case of hypervitaminosis or vitamin D, hyperparathyroidism. Then before we end, let's talk about tetany. So tetany is a condition characterized by increased neural excitability leading to involuntary muscle contractions or spasms. So in tetany, there are involuntary muscle contractions. The causes are hypocalcemia, that is low calcium levels. This is the most common cause. Then hypomagnesia, that is your low magnesium levels can also contribute to tetany. And alkalosis, that is elevated blood pH, also induce tetany. Symptoms include muscle cramps and spasms, often affecting the hands and face. There's tingling or numbness in the extremities. There's difficulty in breathing in severe cases. Now, causes of hypocalcemia. That is, why do you have low calcium levels? So, first and most important can be inadequate calcium intake. You're not having enough calcium through diet. Then, second can be impaired absorption. That is, whatever dietary calcium you're having, that is not being absorbed. Okay, so that is malabsorption disorders. Then, kidney dysfunction. That is, there is decreased reabsorption from the kidney. Then, vitamin D deficiency, because your vitamin D is basically controlling or regulating your calcium levels. Okay, so either there is vitamin D deficiency, therefore your calcium levels are decreasing. Now, diagnostic tests, blood tests to measure calcium and magnesium levels. Your electrocardiogram may show characteristic changes in severe cases. Treatment includes calcium and magnesium supplements if deficiencies are identified. So, supplementation is one treatment. Addressing underlying causes such as correcting vitamin D deficiency. So, in case there is if your cause is inadequate dietary intake, then you can take supplements. But if the cause is something like this, vitamin D deficiency, then there's no point taking calcium supplements. Okay, so therefore, always along with calcium supplements, you're given vitamin D supplements. Okay, they go hand in hand. Then, in case if there is malabsorption syndrome, it is because you're taking enough calcium, but because of malabsorption, that is not being absorbed. So you have to address that cause in that case. In acute cases, intravenous administration of calcium may be necessary. Now, prevention includes adequate dietary intake of calcium and magnesium, monitoring and managing conditions that can lead to electrolyte imbalance. Talking about complications, severe prolonged tetany can lead to respiratory failure requiring immediate medical attention. Chronic untreated tetany can contribute to long-term complications. So that was about tetany. Here we're going to talk about phosphorus. So not very important. Therefore, we've tabulated everything in this chart. Okay, so I'll quickly go through this before ending the class. So talking about distribution in the body, we're talking about phosphorus. Okay, so it is majorly present in bones and teeth. 10% is present in muscles and blood associated with proteins, carbohydrates, and lipids, and remaining 10% is distributed in various chemical compounds. So that was about the distribution of phosphorus in our body. Then talking about the biological functions of the body, of phosphorus in the body, it is essential for bone and teeth development. Then it has a central role in forming high energy phosphate compounds, your ATP, GTP, creatine, phosphate. So all the high energy compounds, they are having phosphate. So there it becomes really very important. It is required for phospholipids. Your phospholipids, they're forming the plasma membrane. Your phosphoproteins, your nucleic acid, DNA, RNA, they all require phosphate. Then component of nucleotide coenzymes. It is also involved in activation of protein and enzymes through phosphorylation, and it also has a role in phosphate buffer system for maintaining the pH of the blood and cells. Okay, so you see your phosphorus, it has very important biological functions in the body. Then talking about the RDA, which is based on calcium intake, the adult ratio of calcium and phosphorus is 1:1. And in infant, the calcium phosphorus ratio is 2:1. Then talking about the sources, milk, cereals, leafy vegetables, meat and eggs, they are the important sources of phosphorus in the body. And its absorption, it occurs through jejunum. Optical absorption when dietary calcium phosphorus ratio is between 1 and 2 and 2:1. So that is your optimal absorption is going to take place in this ratio. Your calcitriol promotes phosphate uptake along with calcium. Acidity favors while phytate decreases phosphate uptake by the intestinal cells. So not just regulating calcium levels, but your calcitriol, that is vitamin D, it is also regulating phosphate levels. So your calcitriol, it promotes phosphate uptake as well. Serum phosphate, that is whole blood levels, and they have approximately a value of 40 microgram per deciliter serum. It contains 3 to 4 microgram per deciliter. Then excretion, about 500 microgram phosphate is excreted in urine per day. And talking about the diseases associated with phosphate, increased in hypoparathyroidism, decreased in hyperparathyroidism, elevated in severe renal diseases. So in case of any renal malfunction, your phosphate level is going to decrease, causing acidosis. Vitamin D deficiency, rickets is characterized by decreased serum phosphate. So in case of rickets due to vitamin D deficiency, there is going to be decreased serum phosphate. And in renal rickets, it is associated with low serum phosphate and increased alkaline phosphatase. And in diabetes mellitus, lower organic phosphate is seen and higher inorganic phosphate is seen in the serum. So that was briefly about phosphorus. So with this, we come to the end of our lecture on mineral metabolism. So we've dealt with mineral metabolism, and in the next class, we'll be starting genetics. If you have any queries, you can ask before I end the lecture. Your iron and calcium are very important, especially your iron deficiency anemias. All your anemias are very important. So with this, we come to the end of the class. See you in the next class tomorrow. Thanks for watching.